Hello everyone, my name is Kerensa Beekman. I'm an MSK fellow at the Amsterdam University Medical Center. First, I would like to thank the ESSR and the Young Club for this opportunity to participate in this fun and educational initiative. And I would like to thank my colleagues at the Amsterdam University Medical Center, Tim Verwest, Floor Groepel, Frank Smithuis, and Mario Maas for their help with this case. So we present a 40-year-old female hockey player. She was a goalkeeper and she flipped over the ball with her left leg, and she instantly had posterior pain in her posterior left thigh, and clinically a proximal hamstring avulsion was suspected. So the first questions were on the normal anatomy. So we're going to look on the right side where she had no pain. So here we go from the knee up. We see the sciatic nerve and the hamstrings located here posteriorly. We see the short head of the biceps femoris, the long head of the biceps femoris, the semitendinosus muscle and the semimembranosus muscle. And again, the sciatic nerve. When we go further up, we see that the short head already disappears, and that's because it originates at the posterior aspect of the femoral diaphysis instead of the tuber ischiadicum, where we can follow the other tendons too. So here we go up, we see the tendon of the semimembranosus muscle and the conjoint tendon of the semimembranosus and the semitendinosus muscle. So the semimembranosus muscle attaches to the medial facet of the tuber ischiadicum, and the conjoint tendon attaches to the lateral facet of the tuber ischiadicum. And when we go further up, we can see here the sacrotuberous ligament. Oh, I skipped a little bit. We can follow that one up all the way to the sacrum. So now we have seen the normal anatomy on the right side, and then we can look at the left side in this patient where she had the pain. And we can see that the two tendons here of the membranosus and the conjoint tendon are not where they're supposed to be. They are missing. And this is what we call the dropped ice cream sign. Here you can see the normal ischiadicum as a ice cream cone with two scoops of ice cream, one being the semimembranosus tendon and the conjoint tendon. And as depicted here on this radiology assistance page, you can see that one of the scoops of ice cream is missing, being the dropped ice cream sign, or in the case of a total avulsion of both tendons, then the two scoops would be missing. So in this case, it's suspicious of a total rupture of both of the tendons of the hamstrings. So the next question was on the to locate the retracted tendon on the coronal T2 fat saturated images. And here we see a large seroma within this seroma the stump of the retracted tendon. So now we've located the retracted tendon. We want to measure the amount of the retraction. So the next question was on the appropriate measurement of the retraction of the tendon, and the correct answer was B. From the retracted tendon stump, this is a different case with a different tendon to the center of the sciatic tuberosity. However, these measurements of retraction are not that repeatable as shown in this article. They only found poor to moderate inter-observer agreements between the measurement of the amount of the retraction of the tendon in a complete hamstring avulsion. The next question was also on the management of this patient. So in our case, the retraction was about 8 centimeters. In the Dutch guideline, from 2 centimeters retraction onward, you can consider surgical treatment, especially in young active individuals. However, this is changing a little bit. So surgeons are choosing more often conservative treatment with also good clinical outcomes, as shown by an article by Van der Made in 2022, which can be seen in the references at the end of the case. And they found that shared decision-making with the patient on whether to choose surgical or conservative treatment showed the same clinical outcomes 1 year after treatment. So in our case, we have a follow-up MRI 4 weeks after the initial MRI. And the plan was to see if the seroma had resolved largely, then the conservative treatment could be continued. And as we can see here, there is a little bit of seroma left. We still can see the retracted stump of the tendons here. But the seroma has largely resolved. So in this patient, conservative treatment was continued. And now 9 months after the injury, she has good clinical outcomes. So to conclude, we've shown a case with a complete avulsion of the proximal hamstring tendons with a seroma and about 8 centimeters retraction, which is consistent with Abamic type 4 injury of the proximal hamstring tendons. And we discussed the hamstring anatomy. We showed that the retraction measurements might be helpful, but they are quite unreliable in the repeatability of the measurements. And we think that shared decision-making should guide the treatment in patients to develop a personalized treatment plan. And both conservative treatment and surgical treatment with this shared decision-making can have good clinical outcomes in follow-up. So these are the references for further reading, and I thank you all for your attention.